The first talk I just want to give you is kind of an overview on clinical correlation in dermatology and dermatopathology. And the timer has started. I'm going to run through this. And there's a lot of people out there who think they can do our field without much difficulty. They think, well, anybody can be a dermatologist. All you got to do is take a weekend course, or anybody can be a dermatopathologist. You don't really have to know clinical derm to correlate with it. But this quote by Goethe, sometimes the hardest thing of all is just seeing what's right in front of you, and that's really true. And if you're going to develop any kind of skill at anything, be it dermatopathology, dermatology, golf, playing a musical instrument, foreign language, you have to have a sort of keys to these mastery. You have to do these various things. You have to have a good approach. You have to have a good knowledge of the details. So you got to spend time looking at slides, testing yourself like we have here. You have to practice. It is called the practice of medicine for a reason. You have to keep doing it, because if you don't do it, you get out of practice and you lose your skill sets. And then you got to learn from your mistakes. And this is a little I don't know what you call it. It's got buttons and whatnot here, but these little birds are saying, sing loud when you don't know the words. And so we always encourage our fellows and residents that they should celebrate when they make a mistake, because they're doing it in a safe environment. And you want to just go ahead and plunge through, because you'll never forget if you make a mistake and you get corrected. So I know a couple of my former fellows are here. They probably know that I've encouraged them to do this over the years. Dermatopathology, it's both dermatology and pathology. So let's start off looking at pathology. How do we go about making a clinical pathologic diagnosis under the microscope? Well, we use an algorithmic method. And what is an algorithm? It basically comes from the world of mathematics. It's basically a step-by-step procedure for performing calculations, but it's useful in clinical dermatology and in medicine in general, where we take one bit of information, add it to another, until we come up with an accurate diagnosis. And in morphology, like dermatology and dermatopathology, we use pattern analysis, because we're looking at things. It's sort of frustrating a lot of times for dermatologists when they first become residents. They're used to being cardiologists and internists and blood testing and looking at x-rays, but when they're a dermatologist, suddenly they're called upon to be able to look at something and be able to make come up with diagnoses. And it's very frustrating for those of you in the room that are dermatology. I remember your first week of dermatology, you felt pretty much overwhelmed, because there are a large number of skin diseases with a lot of overlapping clinical and histologic findings. The good news is, at least they tend to display recurring themes and patterns, and so we can use this to our advantage to come up with a way to actually categorize and then to make diagnoses. But when you're doing this algorithmic method, we like to start off at low power, and we have a saying that we use that my former mentor, Dr. Ackerman, used to say, low power diagnosis, high power mind. So we want to teach our residents to not just zoom in on the high power, start off at low and then gradually work to higher magnification. So it's basically kind of analogous to when Dr. Ackerman really promoted the pattern analysis for histopathology. Basically, you can, if you're doing bird watching, for example, you go out there and you can recognize a bird flying across the sky pretty quickly. Well, that looks like a dove, or it looks like a sparrow, or something like that. So you can kind of categorize it pretty quickly just by its silhouette. And then if you were able to capture the bird with a net or something and look at it in close, higher magnification, if you will, you could add these additional bits of information to be able to make a more definitive diagnosis. So this is really what we do when we're looking at something under the microscope, or we'll see a patient in the clinic. We'll talk about that in a moment. So the first thing is just to take the slide and hold it up and look at it without even a microscope and see how many sections are on the slide, look to see what the overall lesion might have looked like, and especially if you're taking a board examination, I would recommend that you do this. And then I always recommend that you look at it without any information initially, because once somebody has told you something, unless you have a very severe case of Alzheimer's disease, you'll be instantly biased, and you'll never be able to forget what somebody said. So a lot of times people say, this is a 20-year-old, don't tell me. I don't want to know yet. I want to look at it, and then you can tell me they're 20 and they're a woman and all this other material that I want to know, but I don't want to know it initially. And then we like to look at the anatomic side of the biopsy, that certain diseases tend to involve certain sites of the biopsy. We look to see what type of biopsy is performed. We like to get punches for inflammatory diseases. Shaves or saucerizations are good for neoplasms, but not so good for inflammatory processes. And then excisions and incisional biopsies, which we also do. So the very first thing we do after we've kind of done those preliminary things is we want to decide whether we're dealing with an inflammatory or a neoplastic process. It's kind of simplified, but in general, most diseases tend to kind of go towards either an inflammatory or a neoplastic pattern. So how do you tell those apart? Well, it sort of sounds tautologic, but a neoplasm always got some cells that don't belong. They're neoplastic in some way. Whereas inflammatory cell diseases always have only inflammatory cells within them. Now, you can't have both. You can get an inflammatory host response to neoplasms, and you can get some things that sort of don't fit into either one. But as a general rule, we generally we can take most diseases and put them into one of these two categories. So again, we look at these. We look to see where there's nests. We look to see where there's epithelial and mesenchymal cells, et cetera. And then we start looking to see what the overall pattern is that, let's say we're looking at inflammatory disease first, what pattern is being exhibited here. And there are 9 basic inflammatory patterns of the skin. And then we look to see what type of inflammatory infiltrate is present, whether it's mixed, which cell type predominates. And these are the 9 major patterns, and I'm not going to make you memorize this chart right now, but we'll kind of go through these briefly. Superficial perivascular dermatitis, and then we look to see whether the epidermis is involved or not. And this is probably the most common pattern that we see, superficial perivascular with minimal infiltrate, and these are fairly nondescript lesions clinically, so clinicians will biopsy these, and they want you to tell them what it shows under the microscope. This example happened to be an urticarial drug reaction, which caused that. And then we see some that have epidermal changes associated with them. And there's 3 main types of epidermal changes: interface, spongiosis, and psoriasiform hyperplasia, either regular or irregular. There are others, but those are the 3 major ones. These are some other things that we look for in the epidermis that can help us with making a definitive diagnosis. Interface, that basically refers to inflammation involving the area between the epidermis and the dermis. And there are 2 types, both vacuolar, where we get these little holes at the basal cell layer, and then we get a lichen, or we get a dense inflammatory infiltrate of cells in a band-like pattern looking much like lichen planus. And here you see these little small holes in the epidermis in a vacuolar interface dermatitis, and then lichenoid and lichen planus. Spongiosis, very common pattern. Again, superficial perivascular dermatitis, spongiosis, where you get fluid collecting between the keratinocytes. And this was an example of contact dermatitis. And then psoriasiform hyperplasia of the epidermis, which can be either regular, like that of psoriasis, or irregular. And again, these are all helpful things when we're trying to make a diagnosis, and we'll talk about many of these things over the next couple of days. Here's an example of very regular psoriasiform hyperplasia in psoriasis. And then we talk about superficial and deep infiltrates. We're involving both these plexuses as well as some down near the bottom of the biopsy. And discoid lupus erythematosus is an example of that. Diffuse and nodular patterns, where you get involvement with forming little nodules of inflammation in the skin, or very diffuse patterns in the skin. Sarcoid, a good example of nodular dermatitis. And Sweet's disease, an example of a dense diffuse dermatitis comprised mostly of neutrophils. Vasculitis, we'll talk about this as well, again, depending on the size of the blood vessel, whether there's what type of inflammatory cell is involved, whether there's mostly thrombosis, whether you get inflammation. These are all features that we use to help define these. This is leukocytoclastic vasculitis with fibrin in the wall of the blood vessels, and then leukocytoclasia surrounding them with the palpable purpura seen clinically. Blistering disease, we'll talk about that here a little bit later this afternoon. We get both intraepidermal or subepidermal blistering. The intraepidermal, there's 3 major ways that you can get that: spongiosis, ballooning, where the intracellular edema, and then acantholysis, where the cells kind of break apart. And then we have a few others: epidermolytic hyperkeratosis, and then where you get shearing of the epidermis and friction blisters and things like that. Here you see spongiosis, ballooning, and acantholytic, and they can start small as vesicles, and they can get big and turn into bully, and then you can get subepidermal blisters as well. And this is an example of a herpesvirus infection, where you get both ballooning and acantholysis that causes the blister here, viral cytopathic effect of herpesvirus. Subepidermal blisters, again, think of bullous pemphigoid as a common example of that, and whenever clinicians see blisters, they get concerned. And then fibrosing and sclerosing disorders. Fibrosis refers to an increase in collagen in fibroblasts, sclerosis a decrease in fibroblasts with homogenization of the collagen bundles. And morphia is a classic example of that disease. We get conditions that involve the follicles, both around or within the follicles, so folliculitis and perifolliculitis. And there are certain diseases, the acne occlusion triads, things of that nature, rosacea, these can all give you these patterns. Tinea capitis, another example where you see the inflammation and the fungi sitting inside the follicle as a folliculitis. And then paniculitis, we're going to talk about that as well a little bit later on this afternoon, where we talk about septal and lobular, or lobular mostly, and erythematosus, a classic example of that. So those are the major patterns, and then we look at the composition of the infiltrate, and certain diseases will be characterized by some types of cells more than others. Plasma cells, commonly seen in morphia, eosinophils, and bullous pemphigoid, and then others that we'll talk about over the next couple of days as well. So if you go through this, you can actually usually come up with a pretty good clinical differential diagnosis even without information, and then once you get your clinical information, then you correlate that and you do additional studies as required. Now, what if we're looking at a neoplastic process? Well, obviously the first step there is to decide whether we think it's benign or malignant. And again, benign lesions tend to be small, symmetric, well circumscribed, and symmetrical. You kind of remember that, the 4 S's, if you will, whereas the malignant lesions tend to be the opposite. And again, there are other features that help us, whether there is top-heavy versus bottom-heavy, for example, where there are a lot of mitotic figures, necrosis en masse. All of those things help us to define whether something is benign versus malignant. And these are just some examples of benign lesions. You can see that they're very symmetrical, they're small. This is a melanocytic lesion, well circumscribed, very symmetrical. Sebaceous hyperplasia, a little benign neural neoplasm, schwannomere. So these are all very small and symmetrical lesions. Malignant lesions tend to progress from small to large, solar keratosis that turn into a squamous cell carcinoma. Here you see a very deeply seated asymmetrical lesion. And a basal cell carcinoma, these don't tend to metastasize, but they tend to be locally aggressive and very infiltrating. The melanocytic lesions, the histology, they also behave according to the ABCD criteria. They tend to be fairly small, symmetrical, well circumscribed, all the features of the benign process. And then the next thing we do is we try to decide whether we think it's epithelial or non-epithelial, and there are criteria for this as well. Epithelial lesions tend to have the polygonal or round shaped cells that are closely opposed to one another, whereas the non-epithelial ones tend to be more spindle in shape, arranged in fascicles that interweave in many cases. Here you see squamous epithelium, squamous cell carcinoma, that's recapitulating the squamous epithelium of the normal epidermis, and then the basal cell carcinoma recapitulating the basal cell layer of the epidermis, and then a couple of non-epithelial lesions, some neural lesions over here, vascular lesions. Again, these, they may show an epithelioid morphology sometimes, but they tend to be arranged more in these discohesive cells or in these spindle-shaped morphology here. And then the last thing we do is we try to give specific differentiation, where we specifically talk about the types of epithelial differentiation, squamous, for example, versus ecrine or apical or Merkel. And then the non-epithelial, neural, fibrocytic, fibrohistiocytic, and then some of the bone marrow-derived elements. So you put all that together, you can come up with a pretty good diagnosis. So let's switch gears and look at what happens in the clinical dermatologist practice. So for those of you who are mainly looking behind microscopes, it's very important to know what happens when a clinician sees a patient and they write something down on the path rec slip and then sends it to us for evaluation. So it can be done analogous to looking at a microscopic slide. You start off at a low power, you look at the patient overall, and then you move progressively closer, looking at distribution, configuration, et cetera, and you finally synthesize everything together. So the first step, and again, we see young residents walking into the room and they walk straight up to the person and grab their hand and stick it up near their eye. We recommend not doing that. You should step back. You want to look at the patient and see what their age, sex, race, general health is. Look at the overall distribution of the lesions. This guy, obviously, he's got a thyroid abnormality. He's had surgery here and has exophthalmos, and his skin disease was this pretibial myxedema here, the classic location for that. So again, that's very helpful in defining that entity. This gentleman, I mean, a picture says 1,000 words, if you will. He's basically, looks terrible. He had an urticarial drug reaction, an old guy. If this were a younger person, you might come up with a lot of different things to think about. Distributions, there can be specific types of distributions, like this is a stereotypical example of photo-distributed process here. And this is the elbow. There are actually certain diseases that love the elbow. Rheumatoid nodule, for example. There's some conditions that like specific parts of the body. Another example, look how sick this lady feels here. Looks terrible. She's Cushingoid and has this beautiful malar distributed, photo-distributed eruption. She had lupus erythematosus. And then another pretibial process. This is macular or lichen amyloidosis, which also for some reason likes the pretibial surfaces. And then other distributions, we can get widespread processes, unilateral, bilateral, long lines of skin cleavage. All of these give clues to the diagnosis. This lady had pityriasis rosea, and even though we're not looking close at the lesions, we would suspect pityriasis rosea just based on the distribution of the lesions involving the lines of cleavage here, the Christmas tree pattern. a gentleman with a widespread ichthyosis. So we're not even looking closely to see what type of scale is here, but this widespread sort of fish-like scale on his skin, it favors that diagnosis. And this guy's got an erythroderma, total body involvement, and this is seen in a relatively few number of conditions. He happened to have psoriasis in this case. So the next step is you kind of go to a little bit higher power. You're looking for what we call configuration. In dermatology, skin lesions like to assume these very interesting geometric configurations. They can be linear, separated, zoster-form like a girdle or belt. They can be arciform, annular, serpentine, guttate like a little drop, or nummular like a coin. And then they can be grouped, either closely grouped or agglomerated, loosely grouped like a flock of sheep. Corymbiform means you have a central mother lesion surrounded by these daughter lesions, and maniliform is kind of beaded. And this little guy's got multiple flat warts on his face, and you can see he's got several different types of configurations, linear, maybe agglomerated or corymbiform up in this area. This lady had an annular eruption, kind of a polycyclic eruption. This was tinea corporis with a central clearing and the advancing border. And this is a linear process, too, that's not abiding by any normal anatomy. So when a linear lesion does not go along the normal lines of Blaschko or other lines of cleavage, that means it's exogenous. And this was poison ivy. This is where the leaf just kind of rubbed across this guy's skin and gave them a linear eruption. The next step is what we refer to the fundamental skin lesions, and you have to sort of determine which of these you're looking at. Now, I'm not going to spend time going through all of these just for time purposes, but these are basically in the textbooks that you'll hear about the so-called primary skin lesions. I kind of like the term fundamental lesions, like a fundamental building block, because these are the probably 10, 15 ways that the skin can actually manifest as individual lesions in the skin. And many of them you've heard about: macules, patches, nodules, tumors, etc. And I'm not going to go through all of these because I'm sure most of you all either know them or have heard of them. But basically, these are kind of the fundamental number of lesions that skin lesions can present with. Now, one other thing that a lot of clinicians don't understand is that diseases have chronologies, just like people have chronology. They start like babies and they end up very old and decrepit. But every disease starts with an early and then goes through a fully developed and late stage. And depending on when you see the patient, it's going to have different appearances. And the treatment also can affect skin disease. So things can start off as a macule and end up as a patch or papule that turns into a plaque or grows bigger and becomes a nodule or tumor. And vesicles can become bully. This guy had urticaria. And if you look carefully, he's got some little teeny tiny red macules, dots here. And they got bigger and spread and finally got these giant urticarial plaques involving large parts of his body. So all this is an example of chronology. And this guy presents with this kind of grayish, dusky skin. This is day 1, and this is day 5. At the autopsy table, he had calciphylaxis and basically necrosed all of his skin. So depending upon when you see the patient, you're going to see different things. It's also important to look for other morphologic features of importance, the relation these lesions have to a nexal structure, their size, shape, color, surface. These are all very important. And you want to also, this is kind of, we're getting to the point where we're kind of almost like looking at a slide at high magnification. So again, we want to take one of these papules, for example, and decide whether it's follicular or not, whether there's a spine or spike coming out of it. You want to feel it, see whether it feels rough, whether it's smooth surfaced, if it's rubbery. Again, or if follicles are involved, are they destroyed, etc. So this is a guy that's got lichen planopilaris, and notice how shiny that area is. That's because there's no residual hair follicles at all. It's just turned into scar, and there's no hair that's ever going to regrow in that area again. And this guy's got a lymphoma, and notice how it's wiped out his eyebrows. So cancers, when they involve the skin, don't tend to respect the follicles. They just go right through it, whereas benign lesions do respect the adnexal structure, so they won't necessarily destroy them. And then you want to look at size and shape of the lesion. We kind of talked a little about this, the contour. These are classic flat-top polygonal papules with a whitish scale on the surface and these little hyperlinear areas here, the Wickham stria. This is classic for lichen planus. And this is malignant melanoma. Again, so when you're looking at melanoma, you want to assess the asymmetry, the ABCD. So we love to have clinicians write all this down on their path slip when they send in something like this. We don't want them just to put rule out melanoma down there. And then color. Again, color is important. It varies depending on your background skin color. You want to assess whether there's a single or multiple colors, and if more, which one is dominant. And a lot of people sort of think that, well, it's either red, white, or blue. Well, there are a lot of different hues of these colors. Like white, you can get a totally alabaster white lesion when there's virtually no melanocytes. But if there's just loss of the color, like somebody faints, they get white also, but they're not the same white as somebody who has vitiligo. And it's important to kind of become a little bit more of a connoisseur, if you will, of color when you're doing dermatology. This person had vitiligo, so there's no melanocytes here. It's just dead white, alabaster white due to the total absence of any melanin at all. This person has lichen sclerosus, and you can see that it's not quite the same color. This is not depigmented. It's slightly cream colored, so it's a little bit different color than that other white. And same thing with red. You can get brilliant, bright red when you get really dilated blood vessels or red cells in your epidermis, or things can be purple when you get really deep dilated blood vessels. This hemangioma, this child, it's got a very deep, almost port wine type of color to it because these are very large, deep blood vessels that are involved. And this got a very acute inflammatory process, so these bright red, brilliant red because of inflammation. And this is a beautiful picture. It's one of my favorite pictures in the whole lecture because it demonstrates so many different things here. This is an orange-red color, salmon color, very similar to that seen classically in pityriasis rubripilaris. And then he's got this little benign cherry hemangioma here that's a totally different red. So one's orange, one's bright red, and he's got this little pink macular seborrheic keratosis up here. So 3 different lesions in the same patient giving 3 different colors of red. And the same thing with black and blue. You can get jet black when melanin is in the cornified layer. Melanin is basically what squid ink is, and it's just jet black. That's very black, but if you take that same melanin and move it down, it becomes brown. It becomes either dark brown or lighter brown, and then if you get it really deep, it becomes blue. This guy was black because he'd been using silver-containing eye drops for many years, and he used to look like this, so he had argyria. And this little kid had neurofibromatosis and had a nice cafe au lait spot here. It does look like coffee with milk in that lesion there on his face. And this fellow had a explosion where he had a carbon tattoo on the outer surface of his skin here. And this all went away in about 6 weeks, which was due to black. And then you need to feel lesions. That's why pictures are never going to replace dermatology, because you need to actually feel the lesions and squeeze them and see whether they're warm, see whether they're numb. This is psoriasis. You can imagine this is going to feel very rough. And these are the nice examples of the so-called micaceous scale of psoriasis. And these are lesions of steatocystoma multiplex. These are going to feel like little marbles in the skin, blottable. So again, you want to feel whether they're hard or rough. These are when you feel spongy or rubbery neurofibromatosis. This lady had breast cancer, and this felt very, very rock hard when you palpated this. And then we do ancillary testing. Sometimes we rub the lesions looking for a Derriere sign. Again, an urticaria. We'll take a Woods light out, for example. We do scrapings, dioscopy, etc. This is an example of a person with urticaria pigmentosa before rubbing. And this is after rubbing. Get a nice wheel and flare reaction. That's virtually pathognomonic for urticaria pigmentosa. And then the last thing we do in the clinic is we want to picture in our mind where the pathology is going to be and what the histology is going to show, and then put everything together and then come up with a differential diagnosis. And so we like short and sweet differential diagnoses, things that are like 2 or 3 at the most. We don't like laundry lists of many things. That's what happens when you go to grand rounds, but when you're actually looking for a path rec slip sent in by a clinician, we want these to be laser-like rather than shotgun blasts. And then you want to perform the biopsy. Again, if you're going to think about it in your mind, you know what kind of biopsy to perform. You want to correlate all this together to come up with a diagnosis. So here's a couple of examples. This is a 3-week girl that came in with scaling and erythema. The child appeared kind of irritable, small for dates. The lesions were these crusted papules, some linear following the lines of Blaschko, was sent in as epidermolytic hyperkeratosis. So there's a lot of information in that slide. And a good clinical dermatologist probably would come up with a differential diagnosis pretty quickly based on that. Well, here's what the kid looked like, and you can see he's got these linear lesions. There might even be a few blisters here. There's some hyperpigmented lesions, some that are kind of crusted here. And this is the biopsy. It shows a blister here with spongiosis, and there's abundant eosinophils within the spongiosis, as well as dyskeratotic keratinocytes. And here you see that. And if those of you who know anything about pediatric dermatology and this whole process, you'd be able to come up with a diagnosis of incontinentia pigmenti. So here's what happens when you're sitting at the microscope. Biopsy submitted by the clinician. We look at it again without any information. Then we look at the request slip for the information at the end of our initial evaluation, and then we put everything together to come up with a diagnosis. So this is, again, we're not looking at the patient this time, we're looking at the slide. So here's a biopsy, and you can see that we look at it and try to decide what our pattern of inflammation is. It's a superficial kind of dense diffuse infiltrate in the dermis with marked epidermal hyperplasia taken from near volar skin with all these holes in it. And then there's also this white material beneath the epidermis, which represents papillodermal edema, as well as also so-called reticular alteration. And here we see the ballooning degeneration we talked about before. The cells are filled with fluid, and there actually are little small cytoplasmic intranuclear inclusions here. So we look at all this, we put it together, and we say, well, gosh, this is a pattern that we see commonly in some of the viral vesicular dermatitis with the dense infiltrate of lymphocytes and neutrophils and plasma cells. And then we look at the request slip, and we see that it came from a shepherd who lived in central Texas and came in with this boggy plaque of his hand for a week, and their differential diagnosis was pyoderma gangrenosum, bullous Sweet's disease, or anthrax. And so he didn't get the diagnosis, but you, being a good clinical pathologic correlation dermatopathologist, could say, he didn't think of the one diagnosis that can look very similar to these, looking like this, and this was a diagnosis of ORF, which is a diagnosis caused by a parapoxvirus infection. So again, if you just use this method, you'll get really quick at it, and you'll be able to use it whether you're primarily a pathologist or whether you're a dermatologist. And I have some beautiful pictures of where we are sprinkled throughout these talks. At the end, this is actually our garden in the back of our yard down in Edwards, Colorado.